Okay, so today we're going to talk about chapter 21, which is first trimester bleeding. Okay, our clinical problem. Vaginal bleeding in the first trimester is common, but very worrisome to the patient, obviously. So, a sonogram can greatly soothe the maternal fears by showing a normal live fetus. The majority of spontaneous abortions occur between 5th and 12th weeks of pregnancy. I see them usually either fifth, fifth, 6th week before heart rate has developed, or I feel like around 8 to 9 weeks is when I see them. I think it's probably because of formation of the heart, or if there is a chromosomal abnormality, that's when things tend to stop working or developing normally. So there's 7 different types of spontaneous abortions that can be distinguished sonographically. The first one is a threatened abortion, where there's a viable fetus with vaginal bleeding. So you're going to see that as an indication quite a bit. And when you see threatened abortion, it means potentially there's still a live fetus, but for some reason they're bleeding. An incomplete abortion is where there's partial evacuation of the fetus and placenta or incomplete. So that means you can see that there's still possibly some of the gestational sac in the cervix. Um, Things are moving towards a miscarriage, but yet it hasn't all the way occurred during this time. Usually the patients are bleeding pretty heavily. A complete abortion is when there's no retained products of conception, and it seems like everything has been expelled from the uterus. The endometrium could be still a little thickened as the patient is bleeding, but as long as it's not irregular, you don't see any products of conception like placenta or gestational sac. That's what we like to call that. Missed abortion is when you can see a fetus, but there's no heart rate. So you can see the gestational sac, you can see the yolk sac and the fetus, but there's no fetal heart tones. This again is what I usually see this around 8 to 9 weeks. A blighted ovum is an embryonic pregnancy where you just see the gestational sac, but you do not see a normal fetal pole or yolk sac. An inevitable abortion is abortion in progress, meaning that, again, the gestational sac is on its way out. There's nothing they can do. And there's a septic abortion where there's an infected dead fetus or retained products. This can make the patient very sick. White blood cell count will go up. Infection has occurred. Obviously, fever will be a clinical symptom. Let's talk about a little bit about hydatiform moles. It's a condition in which the pregnancy develops abnormally into a form of neoplasm. The uterus is filled with grape-like structures. You can see that there's a lot of little cystic areas here. This condition causes bleeding, vomiting, enlarged uterine size for dates, and the HCG is very high. A D&C is usually performed because this may develop into cancerous neoplasm and spread to other organs. Now, you can have a partial or complete mole. A partial mole, you're going to see some gestational sac, and you might even see a fetus. That fetus is going to be triploidy, though. So they have triple chromosomes and will not be able to survive. You can also have like a complete molar pregnancy where you're not going to be seeing necessarily a gestational sac, but yet the endometrium and the uterus is filled with this grape-like complex structure. So usually an embryo is usually visible about 5.5 weeks. Now, if you guys have been scanning for quite a while now, so I'm sure you've been in a position where you're scanning a patient 5 to 6 weeks, and it's very hard to see that little fetal pole. It's very tiny. A yolk sac is usually visible before the fetal pole. So yolk sac can be slightly visible earlier, around 4.5 to 5 weeks. We always like to do transvaginals with these and not just stick with transabdominal because you're going to get such a better view transvaginally. All right, the fetal pole. Okay, so the fetal pole, the fetal heart motion is visible almost as early as the embryo is present. Now it's very difficult to get, and it might start out slow, like 100 to 110 beats per minute. It is always visible when the embryo is 5 millimeters. If you see an embryo that's greater than 5 millimeters and doesn't have a heart rate, you have to think that this is possibly going to be a fetal demise. If the fetus is sick, the heart rate will be slow or regular, most likely less than 90 beats per minute. Now, in gestational ages of like 8 to 9 weeks, the heart rate is going to speed up, and it can get up to like 160, 170. And then it starts calming down, getting closer to 160 by the end of the first trimester. Let's talk about our pathologies. So a threatened abortion, you're going to have a patient that comes in who's, let's say, 5, 6, 7 weeks pregnant, and they are bleeding. Obviously, they're scared. So you're going to scan them, and you see a yolk sac, you see embryo. You also see a sonolucent area adjacent to the gestational sac. Most likely, this is going to be a subchorionic hemorrhage. The diagnosis is made whenever vaginal bleeding occurs within the first 20 weeks with a closed cervix. And some patients do bleed. The patient is going to bleed more if it's closer to the cervix than if it was up in the fundal uterus. Now, if you see a sonic or SCH, you're going to want to make sure to note the location of the SCH, measure it, and write that in your report. Now, if a patient has a pretty large SCH with a low cardiac heart rate of less than 100 beats per minute, it's probably not looking like a good prognosis for the pregnancy. A lot of the times we will follow up on these SCHs just to make sure they resolve. A lot of the times they'll be absorbed back into the uterus, or the patient will bleed the hemorrhage out. And if a threatened abortion progresses, and if some of the products of the conception are passed as tissue with bleeding, the clinical diagnosis is called an incomplete abortion. The portions of the placenta and some of the fetal parts that may remain with the uterus will result in continued bleeding. Sonographically, the uterus will look enlarged. An empty, ill-defined gestational sac with internal echoes may be seen that are not clearly fetal. In this case, they'll either let the patient see if they can have the miscarriage on their own. They can give medication to help expel the remaining parts of conception, or they can do a D&C in surgery where the doctor goes out and clears everything out. A complete abortion, all products of the conception have passed. Sonographically, the uterus appears enlarged but empty. A line of central echoes, prominent thickening of the central cavity or interface within the uterus represents the decidual reaction, and that may still be present. That will resolve as the patient continues to bleed and heals from the miscarriage. A missed abortion is when the fetus has died but it's retained within the uterus. A missed abortion can usually occur between 6 to 14 weeks. Again, I see this looking exactly like this around 8 to 9 weeks. I feel like that's when it occurs. Now, when you see this, obviously you're going to want to do M mode still, just to make sure, confirm that there's no fetal heart tone. I also like to put color and document it with color that, yes, there is no fetal heart tone. Another thing that is interesting about like a missed abortion is that products of the fetus are going to become more translucent. So it's not going to, the fetal pole is not going to be, the embryo is not going to be as clear as it was if the baby was viable. Again, our cutoffs for this are if you see a fetus that's measuring them more than 5 millimeters with no fetal heart tones, that's a missed abortion. Bleeds in and around the sac are very common. I see them probably like 70% of the time that I scan first trimesters. Bleeds are seen as a group of echoes within the amniotic sac adjacent to the fetus. Low-level echoes in the space between the amniotic and chorionic membranes. They can produce like a crescent shape, and a lot of the times they will resolve. The bleed itself will look different depending on how far into the hemorrhage the patient is. It can be more echogenic at first and become more anechoic as it heals. Blighted ovum is what I like to call it, but it's actually called an anembryonic pregnancy. This means that the gestational sac has developed, but the embryo does not. Clinically, the patient usually has slight vaginal bleeding, and the physician is going to maybe do a D&C at this time, depends on how large the gestational sac is. So even though you're not seeing a fetal pull, you always want to measure the gestational sac so they know how large it is, because that kind of depends on the treatment. Inevitable abortions occur when you can see in this picture, it seems like the gestational sac is very irregular and the cervix is dilated. Looks like everything is about to empty out. And these patients are going to be bleeding quite a bit. A septic abortion is when there's an infection that is either from products of conception that have stayed in there and not been expelled, or perhaps a result of surgical abortion with non-sterile devices. Sonographically, the uterus is going to look enlarged and there are increased endometrial echoes. And then the clinical symptoms of an infection like pelvic inflammatory disease will occur also. So the patient will have high white blood cell counts, fever, vaginal bleeding, probably in pain. Again, our high datiform mole, this is a complete molar here. Vaginal bleeding is a clinical symptom, excessive vomiting, high blood pressure. They all suggest a presence of a mole. Again, if you guys remember from our OB classes, these will also, theca lutein cysts, which are cysts on both bilateral ovaries, could occur from the elevation in HCG. The uterus will be filled with echoes, interspersed with echopenic areas. Large echo-free spaces may occur within a mole, and the process may be confused with a missed abortion or fibroid. However, the HCG will be markedly elevated. Now, in these patients, what we will do is usually a D&C to remove the products, and then they will follow the HCG levels down to 0. Again, that's because this can become a cancerous neoplasm and spread to other organs. So that's why it's so important that we make sure that the HCG gets back to 0. If it doesn't, there could be a cause that like this had spread. Again, this been not benign, but cancerous lesion is called a choriocarcinoma. It's when molar tissue has the potential to develop into aggressive malignancy. It can occur even after pregnancy is completed. However, one good thing about choriocarcinomas, it's very easily treated with chemotherapy. So it's a good mortality rate for these patients, but it is something that you have to watch for. Some moles reoccur after the performance of a D&C and invade the muscle of the uterus. This residual molar tissue is highly vascular and lights up using color flow. Without color flow, tissue may be overlooked. Again, we have to correlate this with clinical symptoms, which is this patient's HCG is just not gone down. That is telling us that there is still some kind of residual molar tissue within the uterus. So what are our pitfalls? Changes in sac shape may be caused by external compression. So if you're pressing too hard, you can actually change how the sac looks on ultrasound. So you want to make sure that you are using enough pressure to penetrate, but not too much. If the sac is located on one side or the other, the uterus, with a relatively thin adjacent myometrium, there's a couple of things you need to think about. This patient could have a bicornuate uterus and have the gestational sac located one of the horns, or this could be a type of ectopic pregnancy, where, and this is like one of the dangerous kinds of ectopic pregnancy. It's because of all the vascular flow that's on the edge of the uterus. So you want to make sure that there's at least 2 millimeters of myometrium in between the gestational sac and the uterus. Other entities may mimic the complex echo pattern seen in molar pregnancy. So again, you got to correlate with your clinical symptoms. You got to make sure the HCGE is elevated. Sonolucent space around a portion of the gestational sac may be seen between 6 and 8 weeks. This is usually venous flow, though. So, of course, when you're looking at a possible subchorionic hemorrhage, put color flow on, because it might not be a hemorrhage. It could be just be low venous flow. A cervical ectopic pregnancy can look similar to an impending abortion. The difference, let's talk critically, with an impending abortion, the gestational sac is going to be very irregular. With a cervical pregnancy, it might not be as irregular. It might look more normal, but still be in the cervix. Another thing to look at is the decidual reaction around the cervical pregnancy. So you're going to see more of an echogenic ring around the cervical pregnancy, and that's kind of can make you tend to think that this is more of a cervical ectopic pregnancy than an impending abortion. Alrighty.